12 o'clock radial scanning. This is valid for left and right breast, and it's easy to think where you are. It's easy to make a position of the lesion, and it's easy when you see it, or the patient has a pain when discussing about focused organ, referring to the Mateusz talk about yesterday. I will try to emphasize and to focus on this. What means radial scanning? So whenever you think about breast, you should think in layers. It's the most easiest way, and is the way I think about breast whenever I perform ultrasound. And the layers are, and you can see it in ultrasound image, is first the skin. Then this is a water bag enhanced ultrasound, but I will come immediate after with a normal ultrasound, so everybody can perform it, even those who do not have the water bag probe. So it's the skin, you get to see the fine lines. Then is subcutaneous fat, that is the same here and here. Then is superficial fascia, this line, and actually is this component, the biological component. Then Cooper ligaments come, and you get to see them in ultrasound. Then you have the entire lobe. You have to think that breast is an orange with up to 15 lobes each. It doesn't matter if you have 12, 10 or 15. We are not able, never ever, to say how many we have. We have to think from the anatomic point of view because we are clinicians. And this is the lobe. It's the epithelial structure, as you heard yesterday. Then you have the fatty tissue below the lobe, the glandular structure, which is here. Then you have the profound fascia. This is a mastectomy. This is the profound fascia. You won't get to see in the mastectomy piece the muscle beyond. But in the ultrasound, you go then to the muscle plane, and then you will have the rib plane. What is important? Thinking in layers, you know exactly where your lesion is. The rate of mistakes decrease significantly when you know where you are. And another thing, when you don't see all the layers and the breast is too large, you cannot perform a correct ultrasound. So you have to say, okay, it's too big, it's not for me, it's not for my probe, it's not for my ultrasound device, and I have to refer to a deeper thing, and then they go to mammography. So this is the image without water bag enhancement. Maybe we won't see, or not, for sure we won't see the skin with the shape, but we did see the skin in the entire structure. We see the superficial fascia, the adipose tissue, the Cooper ligaments, the glandular tissue. And even if this is a normal probe, I can make a side-by-side image, and I get at the end the entire lobe. Then I have the profound fascia, the muscular plane. Here I have the rib. And once you get used to this layer type of thinking, anatomical type of thinking, it's an extra help in your daily practice. For those who are eager to do. What is nice in ultrasound, and we go then in that direction, the topic of today, indication. So again, the entire lobe, this breast was small enough for the entire lobe to fit in one section, so I did not need side by side, but it's a nice view or saying the entire epithelial structure, even the ductal structure, even if with the interior line of the duct. So this is what ultrasound can give you. Very fine imaging, detailed imaging, which are very, very helpful. So we need linear probes. The higher the frequency, the better. It has to be 10 to 15 megahertz, and I had some examples. So this is the side by side. It's a deep, it's a adipose postmenopausal breast. You see all the lines, tissues of cutaneous fat, Cooper ligaments. This is what the remnant of the lobar structure, and this is a 10 megahertz probe. And you will say, it's good enough. Yes, if you have no details. But for example, in this situation, in which this is a side-by-side image, you have in the duct a hyperplasia, and this, when you look in the fine 12 megahertz, this is a 50 megahertz device. You see that this is epithelial structure. This is not transonic. This is not fluid. You have to refer it. You have to look further into it. When you look to the 10 megahertz probe, this is almost transonic. So this will mislead you in direction ductal ectasia doesn't matter. And actually, if you look in the detail with the normal probe you should use to, it's an epithelial structure. What are the current indications for ultrasound? So whenever I have a palpable breast mass, about what Matteo's talked again yesterday, it's a focused sub-symptom type of ultrasound, you should perform it. Breast symptoms could be evaluated. Whenever I have sub-abnormalities, re-emphasizes, and these are ACR and there will also be guidelines. Initial evaluation in young women in which you expect high content of epithelial structures, high hormonal exposure, so you will expect in such young age a wide mammography. Evaluation of symptom in lactating and pregnant women, these special categories when X-ray cannot be used. Breast implants are also something that does increase in the female population, so we should adjust to it even if we like it or not. Axilla is also an important clue and an important region ultrasound can be useful. Of course, guidance of biopsy, but this is for the radiologists who are dealing with breast biopsies. And whenever you have a non-MRI candidate or you don't have any MRI in your city, there's also a possibility, think about ultrasound. First, breast palpable mass. So when you do it, it's easy when you have a breast palpable mass just to put on the mass the ultrasound probe. But if you're still there, use the anatomic way of doing it because it's easy for you to make a consideration. Just put it orthogonal, the transducer, and not to know where you are when you're standing, where is the position of the lesion into the breast. What are the current rules? So it's a correlation with the context. You have to use two orthogonal projection. You have to put the patient in a position in which the thickness of the breast is as small as possible. It's like the odalis position actually that you use. Although surgeon will disagree, saying that if your patient is lying supine and you say 2 o'clock, it's easy for them because if they operate the patient is also supine. So when you put the patient on the side, 2 o'clock becomes 1 o'clock or 3 o'clock, so the position is not the same. So if the breast is not huge, a supine position should do. Always any lesion has 3 dimensions, not only 2. With and without calipers, images are important because when you have calipers, you will have the shadowing of the image. Biret system, it's something that we should use when you are dealing with this one. Have special recommendation with axilla. So position means the layers that we saw. Discuss again, even if this is in the subcutaneous fatty tissue lesion, or we have here a clear lesion, it's always important to know which hour you are, and when you are dealing radially, it's easy to make like in the clockwise thing. And also it's important you can make the measurement to the lesion from the nipple, because always nipple is in the left upper side corner, so you have the distance which is here, and this is valid for all things. Of course you have the measurement, and also you measure the depth of the lesion, which is it's a useful clue, especially for those who perform ultrasound or fine needle or the second evaluation after you. Or I prefer radial and anti-radial section. First I do a radial scan, and according to how wide my probe is, I use it only once if I having the large breast probe, or twice if I have the second, the narrow or the normal probe. And like here, it's a solid lesion, and I have all the measurements. And once I see the lesion, which is a typical position, the TDLU position that Professor Rami did explain yesterday about, I always rotate the probe with 90 degrees, and I have always immediately the third dimension. So I have 2-dimension position to the nipple, to the skin, rotate, have to take the third dimension, and I know where I'm standing, and I know this is a real lesion. What about birods without really not getting into the depth of the birods? Actually, it's important from the PoC-US point of view to know if it's a high risk, it's a low risk, is it a solid, it's a liquid. I think these are the main things that we should take into consideration. So what we should look into? We should look into the orientation, meaning which is the major axis, is it parallel to the skin, and if you are not in the anatomical position, and especially if the layers below the transducer are not horizontal, are like this, it's very difficult to say how does your major axis look like. So it's very important when you perform anatomical ultrasound to have also horizontal layers beyond. Of course, always check that you see all the layers. This is a rule. So you have either horizontal, meaning parallel to the skin major axis, or perpendicular to the skin major axis. Then it's a matter of echo pattern. In breast, echo pattern for the lesions are considering according to the aspect of the preglandular fatty tissue. We never compare the breast lesion with the surrounding breast tissue, because breast tissue is very dependent from female to female, to hormonal exposure, to type of the breast. So you have to have a very, let's say, stable and clear structure to make comparison with. So for everybody, this is a transonic lesion. It's a liquid lesion. It's clear. You can have it isoechoic, meaning similar to the subcutaneous fatty tissue. If you perform layer type, anatomical type of ultrasound, is very easy to know. Skin, superficial fascia, preglandular fatty tissue, glandular tissue, lesion in the breast, not in the fatty tissue. I have the direct comparison, and this is valid for always when you perform it. So I know I'm not a radiologist and I cannot think in images, because I think in hormones and in clinical picture whenever I see an ultrasound and the female. And as you, the vast majority of you being clinicians, you have, I think it's the most easiest way in thinking. Clearly hypoechoic lesion, not transonic, and we have different clues to know that this is a solid and not a liquid one. Again, significant hypoechoic to the fatty tissue, again thinking in layers and re-emphasizing this. And this one is a hyperechoic lesion, hyperechoic to the fatty tissue. So these are the major characteristics. What else? Margins. Everybody who is dealing with ultrasound can make a difference between well-defined margins and again all the layers present, micropolylobulated lesion here, macropolylobulated lesion, or speculated ill-defined margins. It's clear. So actually at the end, if this should not ring a bell in your head, all the others should ring a bell. So the message would be not saying about birods, but actually identifying the high-risk ultrasound characteristics. If you see them, then refer it. And even there are some cancer looking great, looking like a fibroadenoma, the percentage of missed lesions is really small. So actually identifying the high-risk characteristics should be a major phenomenon. Posterior phenomenon, it's clear whenever I have a fluid, the speed of ultrasound will increase, the quality of the image beyond the liquid will increase. So posterior enhancements is re-emphasizing the fluidity of the content of the nodule, and this is clear transonic, and also very nice the lateral symmetric reduction in the ultrasound field. It's a typical sign of benignity. The stronger the stiffness or the epithelial density of the lesion, the most ultrasound beams are absorbed and do not go through anymore. So I am expecting a posterior decrease of the image because of this decrease in ultrasound transmission. So this is not a typical acoustic shadowing, it's a posterior decrease, but this attenuation is a high valuable sign of very high density solid lesion here. It's impossible to think this is fluid and to think this is also fluid when you see this posterior attenuation, which is highly suggestive for the density here. Of course, you have the margins, the solid, the speculated. We have many signs in the same lesion. And the same is valid here in this type of structure. And again, thinking from the anatomic, the layer point of view, you know, you have here the lobule. This is a side-by-side image. You have here the posterior fascia, the muscular plane, and it's clear the lesion here. And of course, you have calcification, ill-defined, inhomogeneity. You have all the clues here. But this is about the posterior phenomenon, which mustn't be completely 100% under the entire lesion. What else? Effect of surrounding. You can have the edema of the skin, and it's very easy if you make a side-by-side image, and then you have like a retraction of the surrounding tissue. Somehow the tumor is just pulling in because of the fibrosis, everything. Of course, you have here in this lesion all the signs that you can possibly think of when you're performing breast ultrasound. Here is a little of desmoplastic reaction surrounding the tumor. Of course, both of these lesions would have been seen also in mammography, but maybe the patient comes to you and say, I have a lump, what to do? If it's a cyst, reassure it. If it's this one, refer it maybe to a colleague, in which the line is not 6 months. Maybe you say it's an emergency and he is able to see your patient in the next few days. This is what the team means. And the same retraction of the surrounding tissue in this high-risk nodule. These are all high-risk nodule. Ductal and skin. So it's a side-by-side. This is left breast, 12 o'clock normal skin. You don't have necessarily to measure it. This is the same breast, the same patient, 5 o'clock. Look how the skin looks like. So whenever you see this edema and all the structures beyond it are, let's say, correctly, this is a high-risk situation, even though in this image there is not a clear tumor. But still, once I get to see something like this, is not, and if it's not after external radio treatment, it's a high-risk image. You don't have necessarily to find the tumor, but a sign should be in your head and refer it. And the same is valid, for example, here what Professor Amit told us about. When you see the lump, go back along the duct and look into it. And here we have a small duct which is seeable, but here we have an enlargement proximal to the lesion. And here is the same. Here is the anatomical side by side. So here is the major lesion, which all the signs, solid, well ill-defined, posterior shadowing, and so on. But when you look along the lobe back, because in the vast majority of cases, breast cancer is not uni-lesional. Even if the patient has only one clear lump, the risk of multifocality goes up to 70%. Here you see an epithelial proliferation, here again. So it's important for the surgeon who comes after you. Vascularity, well, breast cancers are not always hypervascular, so not seeing hypervascularization does not rule out breast cancer, but you have to take it into consideration. And just a quick remark about elastography, since we will have a special elastography talk today. So whenever you see a soft lesion, it re-emphasizes the benignity of your lesion, and the rate of mistake is below 3%. And whenever you see stiffness in the tumor or in the surrounding 3 to 4 millimeters to the tumor, regardless if it's not completely, so all these images are already high risk, and I really did not want to go in further into a threshold and so on. First evaluation in young women. Why? Because you expect a stiff, dense, hormonal epithelial breast. And again, anatomical way of thinking and of performing ultrasound. And you can see ectatic ducts, which are very, very nice to be seen here. Or you see ectatic ducts and here a small lobular hyperplasia, which you can expect. This is also a normal possible appearance in hormonal active females. This is a little bit of intraductal hyperplasia, which we expect especially in the luteal phase of the female. What else? Side by side, here is a hyperplasia, here is the other one, so you should look further into this. And a very, let's say, dense breast with a disease of the entire breast, which is a hyperplasia, the entire lobar hyperplasia. What else? Pregnant women, well, at the beginning of pregnancy, the layers that you usually see are there. The higher the months of the pregnancy, breast starts looking somehow almost like a liver, because the epithelial structure will comprise almost the entire depth of the breast. You get to see some collection of the future milk. This is good, starts looking good, but as long as you go further in the pregnancy, they start to get dense. Once the female is, and this is a better example, lactating, this is also breast. This is typical breast, lactating breast. So from the layers that we discussed, besides skin and the muscular plane, everything else is an epithelial structure in which you could see fluids, ectatic ducts, or like in the next example, a galactocell, which sometimes the female can palpate without having pain, tender fever, redness of the skin, and so on, reassuring that there is nothing. Yes, and these are special category of females who maybe are very, very sensitive and very stressed. In this situation, it's clear a lactating breast, but this is already an abscess. So if you see this multi-layer tumor-like high-risk type of lesion, send it to surgeon, not necessarily to punction, but this is an abscess and it needs surgical treatment. This is a complicated galactocella which can be postponed as treatment as the female will finish lactation. And in this situation, it's a typical mastitis. Of course, mastitis is easy to be diagnosed from the clinical point of view, but in my experience, there's some females coming in being frightened about the tumor, reassuring that it's only the typical mastitis with edema in the subcutaneous fatty tissue. Breast implants, actually you have to check two things, that they are beyond the muscle, and the best point to see it or to look into it is in the super-external quadrant, in which you see performing anatomical the layers. You see here the muscle, and there is a small line going over the implant, and then what is below the implant you don't get to see. And the rule in implants are very, let's say, simpler from the clinician point of view. You have to find lines. They have to be parallel with very, very small space between them. Because female with implants have two major problems. Actually, they have one major problem when they came in, let's say, symptom-focused evaluation. The fear of implant rupture, and as long as the entire implant has these fine thin layers parallel with small, very small and narrow space between them, there is not a huge problem. But whenever between the lines, so this is muscle plane, this is one line, and the second line is here. So whenever there is an inappropriate space, an inappropriate something there, refer the patient, and this is the same here, to somebody who knows a little more about this. Last but not least, male ultrasound can be also interesting. I think the best way in learning breast ultrasound is starting with males, thinking in layers, because from the anatomical point of view, the layers are excellent here. Of course, here is a male with a strong pectoral muscle, according to all the examples from the females that we saw before, but the layers are the same: skin, superficial fascia, preglandulary fat. This is a fibrotic remnant that has nothing to do with the problem. But in this situation, besides the fatty tissue, which is clear, the fatty tissue here that is clear, and the muscular plane, here is already a lobe, which is fibrotic, which has no epithelium at all, which has no tumor inside but is there. So this is an inactive gynecomastia that has to be, how should I say, re-emphasized that it exists, and this male should be attentive and with his evaluation. This is the same very, very nice image. This is not adipomastia. This is a ductal remnant. I think this is the best way of thinking from the anatomical point of view as a clinician. And again, you do not need the special 9 centimeter probe. You can use it with conventional. So usually I come with other examples, but now I did change to conventional probe just to re-emphasize that everything that you can do with a large probe, you can do with a normal one. And of course, this is also a male. Even if it looks like a female, all the layers, skin, subcutaneous fatty tissue, here is really epithelial structure. Moreover, I see heel epithelial proliferation that goes along inside the duct. So this is a florid gynecomastia. So I re-emphasize this one to go to endocrinologist and to make complete checkup. I say, okay, it's not still a tumor, but this one has to be treated. And this one has to be just follow-up, and this one has nothing. So it's important. So the potential patients that can come in our labs are really, really big. What else? Just a short axilla, and then I have to finish. So I'm not a specialized radiologist. I do not want to become one. Rules for lymph nodes. You get to see always in the axilla at least one lymph node. And the rule is it should be lower than 2 centimeters. It should be the ratio between the longest and the wide to lengths below 2 to be ratio of 2. And the cortical thickness should be less than 3 millimeters. And so this is a good looking, it's a 1.2, the hilum is central, the cortex it's small. Whenever you have more than 2 centimeters, even fatty lymph nodes bigger than 2 centimeters and cortical higher than 3 millimeters, according to the ACR, should be considered abnormal. So this one is already an abnormal one. Even if it has hilum, it has this bulge here. So even if it's below 2 centimeters, consider it to be aware of. This one is an oval, 1.2 centimeters hilum. Cortical is good. Don't take it into account. This is also a nice one, but going in better this example, this one should be considered a high risk lymph node. And just a short comment about the limits. Macromastia, it's a limit. So whenever you don't see like in this example, so it's a blurred image. I'm 8 centimeters deep here. I don't see the muscle plane. I cannot rely on the ultrasound. I have to be confident saying to my patient that I cannot, even if with a water bag probe, I cannot deliver a correct evaluation, so she has to refer to something else. Calcifications are a problem in all ultrasound evaluations, and whenever you see it, you have to refer it to mammography, especially in such situations. Shear wave is a helpful tool, but not a universal one. And what else? Just before to have my 30 minutes take-home message. Evaluation is possible with ultrasound regardless hormonal level. You don't have to make a break in the supplemental treatment, hormonal treatment in postmenopausal women. You don't have to have a special hormonal or a special day as you need in mammography and MRI to perform ultrasound. There are special categories such as pregnancy, lactation, adolescents, in which ultrasound is preferred. You can see the epithelial component of the breast very, very, very nice and very easily, even if before you have peritumoral reaction. You might get occult cancer. It's an important tool in evaluation, the implant pathology and the gynecomastia. And for all of you who are, from the clinician point of view, interested in breast evaluation, we are organizing in Timișoara breast ultrasound 2-day course, only breast, and we will have a multidisciplinary team. We have a radiologist, Professor Chura from Cluj. We have Professor Dominique Ami, who is expert in elastography, and not only who is the promoter of thinking anatomical, the so-called ductal breast ultrasound. We have Sherban Costa, which is a professor of gynecology. He's a Degum Drai in Magdeburg, previous chief of Magdeburg staff. And last not but least, we as a team, as usually, are there, and behind we'll have the PoCUS, breast PoCUS, just to see the specialist, the organ specialist, how much the medical, the general practitioner can do for ultrasound. It's an EFSUMB endorsed course, and you are welcome if you want. Thank you.
And I decide to select not the best pictures I have. I select some pictures from 8 or 10 years ago because the anatomy and the physiology is not imaging dependent, but for physiology and anatomy dependent. So I am going to now try to develop elastography. Many people think that elastography is a joke, just to try to see benign, malignant, and no, you will see that elastography is something very interesting, and you have a lot of information going through the elastography. Very fast, you know that you have two types of elastography with MRI or ultrasound. Few people use magnetic resonance because it's very expensive and you have few machines. With elastography, you have strain echo and shear echo, and so you have quantitative or qualitative echoes, two different type of echo. I had the chance to work with the pioneer of the elastography, the strain elastography from Hitachi, and here the shear elastography from supersonic imaging, which is now Hologic company. With strain echography, the Japanese people create the Tsukuba score classification in 5 scores. The score 1, you have the B-mode imaging, exactly superposal to the elastography image, and you have here the green homogeneous perfectly designed score that's really benign. Then score 2, the same size between B-mode image and the color map of the elastography, but with some blue signal in the center or heterogeneous center. And then we jump to the score 4. 4, you have the same size of B-mode image and the elastography strain echo, but the internal echo are really blue, deep blue. That means for the Japanese people, hard. High suspicious of malignancy, and score 5 is image in elastography larger than in the B mode and completely blue with a small blue light crown around the lesion that you assert score 5. You can assert. The most important is the score 3, which is here, benign or malignant. That's a very important discussion. But usually we use the elastography with this score, and you have a specific score for the water, so for the liquid, hematoma, abscess, lymphocell, and you have the blue, green, red signs. It's a specific signs. It's not elastographic signs. It's just a physical relation. And then I show you the picture of the long lobe here, hyperechogenic, and with 3 small hypoechogenic structure, irregular, taller than large. And how can you assert that it's a malignancy? Here you go to the strain echography, and you have here the characteristic blue with a light blue around. You assert score 5. It's a malignant disease. Plus, we have no time to explain you that you are going to make a ratio between the fatty tissue, subcutaneous fatty tissue, and the lesion, but it's helped really. You have to know that you have 2 techniques, the strain echo, external constraint, and the Shear, internal propagation of the waves. And the Hitachi Japanese company was the first original pioneer, and they create the blue like very suspicious lesion. I ask them why blue, because they say, oh, we have a questionnaire with all the doctors, and they say blue for us is something suspicious. And for the Shear technique, supersonic imaging in a European company, and they decide that the red will be highly suspicious of malignancy. So you have an opposition of color, blue for the Japanese, and here red for European. But it's, if you have any problem, you can move and change the color. It's just like a video game. But you know that here the company will give you the rule of the here the blue, green, and here the red zone, which is the zone of the malignancy. Shear, yesterday you had a lecture, and they explain you that you have the propagation of the waves into the breast, and you have no movement of the probe on the skin. Just put the skin, you wait 5 seconds minimum, 8 seconds will be best, and that the result appear. And the specificity of the Shear, they give you results with a number of kilopascal. That's something very, very precise. And you know here that the fatty tissue correspond to 0 to 20 kilopascal, the glandular tissue till 0 to 50%, and then over is highly suspicious of carcinoma. But if you look here, and we will discuss about that you have here some specific zone, and you have some soft carcinoma. Mucinous, colloid, in situ, and they look like here fatty elasticity. So this technique is perfect except 10% of the cases where you have some doubts. But we have the Doppler, we have the B mode, we have the X-ray, and all the other technique to promote the good diagnosis. It's very easy in sample. With your probe, you select here the lesion, follow the DANA instruction, and you have very fast the hypoechoic lesion with the involvement of the duct, so you can make Doppler, measurement, and volume. Immediately, if you have the chance to have a 3D probe, you make a 3D plane analysis and the Shear, and it took less than 3 minutes, and the lady can leave, and you make after that all the reprocessing analysis for the examination. And if you have the chance to have a 3D probe, you can make multi-slides analysis or a sagittal, longitudinal analysis, and you can make a good analysis of the prolongation, the involvement of the carcinoma in the surrounding tissue, in the Cooper ligaments, and in the glandular tissue all along the duct axis. And you have the correspondence with the B-mode images and the Shear analysis. Now we start with the routine daily work. I had not a lot of lobe like this one. Have a look to this one. It's a 40-year-old woman. You have the long lobe like that. And here you have an anechoic structure. That means you have liquid because you have no cells. It cannot be malignant. That's a cyst. Here you have a typical polylobulated solid-like fibroadenoma. But following this lady, it appears a specific zone between the two benign lesions. How can I analyze that? I focus with a special probe here on this area, hypoechogenic, speculated duct involvement, plus here real vascularization with Doppler. High vascularization. And here the elastography. Elastography that give you information that you have modification of the elasticity of the tumor itself and the surrounding tissue. Why here we have a blind area? Because elastography is not working in liquid. And so you have here the arteriovenous shunt, liquid area, and you have exactly the transformation to the blind area. So you are sure that here correspond to this vascularization. So it's a very, very precise analysis. And with the 3D, you can make the orthogonal involvement of the tumor. And you see that the center of the tumor is not really active. In the desmoplastic reaction around the tumor, here you have a lot of modification with edema inflammation. So after the diagnosis of the tumor itself, now you can go to the diagnosis of the lymph nodes. I will say something very important, that I am disappointed with the lymph node analysis. B-mode, Doppler, and elastography give us some information, but not enough from my point of view. And you have several localizations of the lymph nodes, axilla, parasternal, under the ribs, and the deep, and we cannot see all of them. You have a typical inflammatory lymph nodes. The ileum completely disappear. The here the lymph node is hypoechogenic with hypervascularization. Maybe it's inflammatory, but you don't know. And you have to, if you are interested to the analysis by elastography, you have to go to the publication of Dr. Fournier, a Swiss colleague, he make a very interesting analysis, and he tried to perform Doppler and elastography on the lymph nodes. You see the lymph node has a completely different pattern than the normal one, hypervascularization, and so you will not have elastography information here, just there, here, and he had 24, 25 kilopascal, and that means for him it's really at metastatic lymph nodes. And using this perfect technique, he is able to avoid 40% of the lymph node sentinel procedure, because he asserts this lymph node is metastatic, so you don't need to inject blue or radioactive liquid in the lymphatic system. This lymph node is a metastatic one. After the diagnosis of the tumor and the lymph node, elastography will really help you to guide your echo-guided puncture. You see the huge difference between to detect the lesion here and how you are going to put the needle in the good area of this lesion. But following the elastography, you have a good contrast, and you know that you have to try to put the needle in the light blue zone around the deep one here. It's a Shear analysis, and the same patient with the here Shear technique, 3D technique, and you have here, you know that here you have to maximum active metastat cancer activity, and you have to put the needle here and not there. So it's a great help to follow to guide the needle for the puncture. In case of microcalcification, they are not specific. Sometimes you have less or very, very small microcalcification. How can you know if it's something with a carcinoma? In some rare cases of diffuse no-mass cancer, you use elastography, and you have a really good answer. You have a wonderful here Doppler with the analysis of the modification of the vascularity in this zone here, and here the elastography, and you should have numbers that over 150 kilopascal, and you can assert it's a carcinoma. It's a diffuse carcinoma. It's a no-mass cancer, but you have malignant cells. Another very fascinating power of the elastography, and to try to help you and to make the prognosis of the tumor. Professor Evans, several years ago, had made very interesting work comparing histology and the elastography of the Shear technique, and he has a cutoff value of 50 kilopascal. My feeling it's a little low. Sensitivity 97%, specificity 80%. And he found that if you increase the stiffness, you have a more invasive and aggressive carcinoma. He showed us a medullary carcinoma, poor signs on the mammography, not evident signs on elastography, 2D echo, but here few modification of the elasticity. It's a non-aggressive medullary carcinoma. Compare to here the ductal carcinoma with a big stroma reaction on mammography, big modification on B mode, hypervascularization on Doppler, and here you have a really high level of kilopascal. You can assert it's a score 5 of an aggressive tumor. So the surgeon and the oncology team know that they should select an adapted attitude to try to cure this lady. And the way of controlling the efficiency of the preoperative treatment, chemotherapy, is to follow by elastography the modification of the elasticity, and you can make a good analysis of the reactivity of the treatment and adapt the treatment to each patient. 50-year-old woman, not evident carcinoma, difficult to detect, but palpable, and you have here a good reaction with more than 150 kilopascal. Then after 3 months of treatment, you see the huge modification, the inflammation, the edema decrease. That means that the treatment is efficient, and if you have a chance to have a 3D probe, you can make a better analysis of the modification of the elasticity of the carcinologic process and then the reaction under the treatment. So you select a suspicious zone, you make the analysis of the elasticity, you assert it's a score 5, and you help the oncologic team to say, please try to select this treatment or another one, preoperative, to give all the chance to the woman to cure the disease. And now a new development, Professor Ueno, the guy who created the strain echo in Japan, and he tried to make an analysis of a non-mass cancer epithelial transformation. With echography, we are able to see here the modification between the X-ray information, and so we try to see the hyperplasia, the atypic hyperplasia, borderline, ductal carcinoma in situ, and the invasive carcinoma. And we try with elastography, each try with elastography, to make difference between the normal epithelial, hyperplasia, and here invasive carcinoma. And to do that, he make another classification with 5 levels, and he tried here to the cluster micro-classification with suspicious zone. You have a score 5, and you assert, take care, don't say that only microcyst, but you have something wrong, and it should be carcinoma, and then you make an echo-guided puncture. You understand that elastography is not a video game, it's not a joke. It gives you a lot of information, and you are going to have a very acute diagnosis and help in the diagnostic and the treatment of the woman. Of course, like every technique, we have some limitations, and sometimes if you press too much, you can assert that a cyst become carcinoma mimicking, or reverse, you have some benign appearance for small carcinoma, but it's just a training, and you know sometimes you have to make pre-compressive analysis, but all the case proposed by Professor Barr in America was obtained from big fatty breast, lot of fatty tissue, poor or epithelial structure, and so the fatty tissue in echography is water equivalent, and so it's easy to have some modification. But just with the training, we can avoid this problem. So my conclusion, that today I cannot imagine to make a diagnosis of a breast tumor without elastography. It's a good, necessary, complementary technique. In my experience, I can do the diagnosis of 90% of the minimal breast cancer. Minimal breast cancer is not my classification, it's international classification between half centimeter to 15 millimeters, and that small carcinoma, if you can detect and treat the carcinoma at this size, you give the better chance to the lady to be cured and safe. And if you had the Doppler Elastography B mode N plus, of course, you will use the other technique of mammography, MRI, etc. But you will make a good diagnostic, except for the 10% of soft cancer. I repeat, in situ, colloid, mucinous, diffuse. But maybe they give you sorry, they give you other signs, microcalcification on mammography, maybe hypervascularization in MRI, so we can try to uh, avoid some mistake. And we hope that we can, with the new technique, the best machine like Dana showed you, we can make an analysis of the no mass cancer, which is a new technique in development. And with the elastography, we know today that we can avoid 50% of the biopsy. And you know that it's a huge market, very expensive, aggressive for women. So if we can avoid this step in the diagnosis, we will make great help to the ladies. Last slide. If you are interested by more and more interested by the analysis of the ultrasound for the breast, you can read the book of Todd Tibor, the anatomopathologist, the father of the sick lobe theory. And in this book, with many colleagues, we make a good analysis of the lobar approach to breast ultrasound. Thank you for your attention.
Thank you very much for the kind introduction and for inviting me here to speak in this conference. I'm a Professor of Imaging Sciences at King's College Hospital in London, and I've had an interest in the testes for quite a number of years now. And I'm going to do this talk with you today by showing you how you use multiparametric ultrasound in your testicular practice by using that incidental lesion that you see when you're doing a scan, that you don't really know what it really is, and how you can bring in all your new techniques to help you along the way. First of all, I'll just, as everyone else has from EFSUMB, touch on the guidelines, because the guidelines are very important when you're looking at testicular lesions and you're using the newer techniques of contrast-enhanced ultrasound and elastography. Remember that ultrasound is the imaging modality of choice in the scrotum. You're not going to use CT, and I'm a radiologist, and everyone in radiology only wants to look at CT or MR, but ultrasound is the most important investigation for the testes. And occasionally when you're doing this, and particularly when you're seeing patients with symptoms not related to what you find, you got an equivocal lesion that you don't know what it is, but your ultimate aim here is to try and make that diagnosis of what it is to prevent that patient losing that testes. And I'll come on to this in a little bit of time to demonstrate to you that you've got to save these patients. At the radiologist, you've got to save these patients from the urologist, because urologists are operators. And the particular difficulty is to tell whether or not a lesion is hypovascular or vascular or avascular on your ultrasound Dopplers, because the teaching is that if it's vascular, it's a malignant lesion. And again, as I go through this talk, I'll show you that is also not always true. By addition of contrast in your examination looking at the testes is a practical solution for this vascularity, and we'll show you this because contrast-enhanced ultrasound will stop you worrying about whether that lesion is vascular or not vascular. And the guidelines in 2011 on non-hepatic applications and the update in 2017 both had sections on using contrast-enhanced ultrasound in the testes. And we'll also go on to the elastography. The recommendations of adding a parametric ultrasound examination to your study, and in this case contrast-enhanced ultrasound, was to be able to distinguish between vascularized and non-vascularized focal testicular lesions, to distinguish between non-viable lesions in testicular trauma, identify segmental infarction, and identify abscess formation. And you'll see nowhere in the recommendations when you add contrast-enhanced ultrasound to your baseline ultrasound examination does it tell you can actually say what sort of tumor it is. So beware that they are very limited. In 2018, and we've seen that the elastography was introduced to the guidelines, and we've seen how elastography is particularly useful in breast imaging, but how useful is it in the testicular focal indeterminate lesions that you find? Probably not as good as breast lesions, but we'll tease this out as we go along. So the recommendation in the elastography guidelines for focal testicular lesions, it could only be recommended in conjunction with other ultrasound techniques because there's so much overlap, and we'll see this as we go on. So what's the background to that incidental indeterminate testicular lesion? More and more often, male patients will come to you with vague symptoms of the testes because they're worried. Usually it's because some famous footballer the night before declared on television they have testicular cancer. The next morning, everyone is knocking on your door. They too have testicular cancer. And we see this all the time. But when they say symptoms were on the left, you found something in the right that's too small to be actually palpated. So what do you do with this lesion? There's a focal lesion in the testes, and this is the incidental indeterminate testicular lesion that you'll pick up. The European Society of Urogenital Radiologists have issued guidelines on how you manage this incidentally detected non-palpable testicular tumor and how your imaging findings impact on the management of the patient. When we look at the lesions in the testes, they're much wider spread of different lesions that you can see in the testes. There is, of course, the malignant lesion, and the malignant lesion is orchidectomy. You have to take the testes out because the remainder of the testes is susceptible to a malignant tumor. Having said that, most of the malignant tumors of the testes have a good prognosis. 90% survival at 5 years if you catch it early. So the main malignant lesion is the germ cell tumor, and this may be the seminoma, which may be pure, or you may have a mixed germ cell tumor. But you can also get tumors arising from the sex cord and the stroma, which are the Leydig cell and Sertoli cell tumors. And not all Leydig cell tumors are malignant. In fact, 90% of hyperplasia are not. Rarer tumors include leukemia and lymphoma, but these are very rare. But you've got a whole bunch of benign lesions that may mimic the malignancy that you see in the testes, ranging from the epidermoid cyst to post-trauma, post-biopsy, simple cysts, or even an abscess formation. The main thing here is to realize that clinical medicine or clinical urology lags behind the imaging techniques that are being developed. So the clinical practice in urology is slowly changing to what you are now finding on imaging techniques. So the old urological practice was orchidectomy. If you could feel a lump in the testes, this may not always be true any longer. And this is a whole array of tumors that you'll see. These are the malignant tumors that you'll pick up in the testes, but hidden among these malignant tumors are a couple of benign tumors that don't warrant orchidectomy. And why is this important? Because it affects the young male patient. And the most common palpable intratesticular lesion in young boys and men between 15 and 34 years old is a malignant testicular cancer. The highest incidence of a malignant testicular cancer is in Denmark and Norway, and that's 6 per 100,000. So it's not a common tumor to find. But it is important because you're dealing with a young adult male patient. You're going to have affect his prognosis and his ability to have a financially secure future, and also you'll affect fertility by doing an orchidectomy. So we are seeing an increasing detection of small testicular lesions may not warrant all the management that you've had before with finding a malignant lesion. So what are you going to do? So what is an incidental lesion? Well, it's a very busy slide here, but the take-home messages are that you'll often find a simple cyst. A simple cyst was thought to be rare in the past, but as you go, we do more and more ultrasounds, you see simple cysts more often. If you see a solid lesion in the testes, again, the take-home message here is that 80% of these solid incidental lesions are benign, but you have to find out and pick out those that are benign. And a couple of studies have shown that if you find an incidental lesion, 45% are Leydig cell tumors, 45% are epidermoid cysts, and 10% may be malignant. Often a nodule coexists with infertility, and you want to avoid orchidectomy in patients who are subfertile, because this affects, of course, their ability to conceive. This is the most important paper that's come out in a number of years, where they looked at a cohort of infertile men looking to see how often they found these incidental lesions, and they found them quite often, and this is that demonstrated that 80% were benign. So you want to avoid taking out that testes for that small lesion that you can't feel that you found incidentally. So what is the size of an incidental lesion that's non-palpable? There's a lot of argument about this, and these are older papers now, and ultrasound is changing all the time. So this is a paper from 10 years ago where they suggested that a non-palpable lesion may be between 10 and 15 millimeters in size. Well, we're seeing them down to 2 or 3 millimeters now. What are you going to do with a lesion that's only 2 millimeters in diameter? So benign incidental lesions we can put to one side. The simple cysts, frequent, benign, do not require follow-up or surgery. Solid tumors, we need to look at them more. 80% are benign, probably Leydig cell tumors. If you've got microvascular or macrocalcification, you've got to be worried about the underlying malignancy developing. And if you've got a complex cystic abnormality, you need to look into that more. But it's those newer techniques that are coming through that you need to know about, and you need to be able to use to make sure you come to a conclusion for that incidental lesion. Year 2000, Campbell's Urology is the 8th edition, and this is the United Kingdom's standard textbook on urology. Any 15 to 34-year-old who has a palpable testicular mass most common lesion germ cell radical orchidectomy. Year 2021, you're doing patients come in for a variety of reasons who have pain. New techniques are available. You can tell the difference between benign and malignant. You're finding incidental lesions, and it's the radiologist who's in control, not the urologist, in determining whether or not that patient ends up having an orchidectomy. 80% benign. But you as a radiologist, and this is the only time a radiologist ever actually speaks to a patient, I know you're all clinicians here, but the radiologist sits in a dark room with CT scans and never sees a patient until they retire and they become one. You are going to speak to the patient, and the most important thing, and the ultrasound couch is like a psychiatrist's couch. It's a dark room, you're putting warm jelly on, and you're talking to the patient nicely. So you get a lot of history, and it's very important, the history as well, when you've got this indeterminate lesion. Pre-test probability. Was there a past history of undescended testes? Was there a previous history of testicular tumor? Is there a family history of a tumor? Is there, when you're looking, testicular microthiasis and macrocalcification? Ask the patient, is there pain? Is it painless? Is there infection? Was there trauma? So often a young male patient with a focal lesion in the testes, which is a hematoma, won't tell you they've had trauma because they can't remember what happened last night when they came away from the bar. Don't ask their friends, they were doing the same thing. So you got to get a history from them. And what are the tools that you have? Well, the B-mode ultrasound is the most important tool here because it tells you quite a lot from there. Adding color Doppler increases that. Contrast in Smart Ultrasound takes you to another level for vascularity. Tissue elastography or strain elastography, shear wavy elastography is very good as well, but you need it to use it in conjunction with everything else. And then the offline investigation of the CUS curves after the injection of contrast are also very important. Pretest probability, well, you've got the age, 15 to 34. Cryptorchidism, risk of a testicular tumor 4 to 8 times the normal population. If you've had a tumor in the contralateral testes, you have a much higher risk of developing a tumor on the other side. It's the background issue of a risk in both testes. And the family history, 4 to 8 times. Risk for related cell hyperplasia, you've got Klinefelter's disease, or you've got infertility. It's much higher to have the stromal cell tumors in these patients. Age, well, it's that 15 to 34, but there's a second point in the 60 to 65 for a risk factor for a germ cell tumor. Trauma, infection, granulomatous disease, sarcoidoid TB, genitourinary TB, you've got to worry about that. Inflammatory pseudotumor, has the patient had recurrent epididymitis? Leukemia, lymphoma, congenital adrenal hyperplasia, and whether there's gynecomastia at all. Congenital adrenal hyperplasia presents a unique problem because very often these adrenal rest cells are bilateral, and if the patient hasn't been taking their therapy, they're going to get much bigger. But of course, the young patient, the young male patient, will deny they're not taking their medication, as they would, they deny they didn't have a drink last night and fell down and injured themselves. So what techniques have we got now? Well, we've got all those techniques that I've mentioned before, and this was stimulated a number of years ago, where there was a paper in Clinical Radiology, which is a journal in the United Kingdom, which looked at indeterminate lesions, but made no mention of parametric ultrasound imaging. So we brought this up and indicated them that with these new techniques, you're going to be able to get much closer to the right diagnosis than you are with just your B mode and your color Doppler ultrasound. And this is the terminology we now use, multi-parametric ultrasound imaging, because don't be ashamed of how many different things you can do with ultrasound. Don't let MRI tell you they've got multi-parametric imaging and they're much better. No, ultrasound is much better in the testes because it's the best technique to show those 1, 2, 3, 4, 5 millimeter lesions. Let's just concentrate on the vascularity. Now the teaching is your malignancy is vascular, non-malignant is avascular. All this stems from a paper in 1992 where they looked at 28 patients with surgically removed testicular tumors, and in those days, and this is 30 years ago now, they couldn't find vascularity in that tumor if it was less than 1.6 centimeters in diameter. Now that's huge. You were going to pick up vascularity in something that low, but they made a conclusion that only a limited role. Well, that's not quite so true, because with just color Doppler ultrasound, you can pick up flow in quite small tumors, maybe 4 or 5 millimeters. But the new kid on the block is microvascular imaging. This is a very sensitive Doppler technique. And this is a tumor that's 2.9 millimeters by 2.7 millimeters. And if you don't know how big that is, take up a ruler and look how big 2 millimeters is. And this is how phenomenally good you are with ultrasound. And this is how phenomenally good the sensitivity of color Doppler is at picking up that flow within that small lesion. So you've improved from that thing, and you can dismiss that vascularity thing. But it doesn't always tell you whether this is malignant or not, because not all lesions that are hypervascular are malignant. So you've got to do more work on this. And there's a paper about 5 years ago looking at the same sort of theme. They retrospectively looked at all their practice, and they came up with a conclusion that not all malignant lesions show vascularity. They were using color Doppler, and they couldn't. Very often they got a malignancy, but they could never see color flow in it. They didn't add contrast. Now this is a embryonal cell tumor, and when you add contrast, you can just see very tiny little bits of microbubbles going through that tumor. If I can find is my thing on the screen. Anyway, you can see very small bubbles going through there. So if you've got a bubble going through a tumor, it's got a vessel, because the microbubble is truly intravascular. It doesn't leak. So that area is microvascular. But what you can use is a MIP technique, where you summate those microbubbles. And in this lesion here, which has got a little bit of color, you can see as you maps it up and summates it, you can see that you've got vascularity in that tumor. There is no doubt this is a vascularized tumor. But this isn't an incidental lesion, because you can palpate it. You can see that there's indented the surface of the testes, and it's palpated. So it's not an indeterminate impalpable lesion. It becomes a lesion that you can feel, and that's different from the indeterminate one. So you can now demonstrate vascularity to a very low level. But how good is it at improving your diagnosis by adding contrast-enhanced ultrasound? This is a study we did recently, published in the UMB, over our 10-year experience with it. And we divided into experienced and inexperienced operators, and you add contrast to your examination. And did it improve your assessment of the vascularity? For the inexperienced, it brought them right up to almost 90%. For the experienced, it brought them up to 90% from a high level from the inexperienced. So you're very good by adding contrast-enhanced ultrasound to determine whether or not that lesion is vascularized. So that's good. We can now say adding contrast tells you whether that's vascularized or not. Now let's move over to elastography. Now, most of the experience with focal testicular lesions is with strain elastography. And as we heard from Dominique earlier on, the Hitachi machine was really very good at strain elastography, and gave you really very reproducible results. So we looked at, this is our study looking at visual score, where you, similar to the breast score, we had a testicular score, and you could tell whether or not it is hard or soft, and also looking at the strain ratio, giving you a numerical value. And you can see there's a huge overlap between malignant neoplasms, benign neoplasms, and benign lesions. Benign neoplasms meaning those that are vascularized, as opposed to those that are not vascularized. The Leydig cell tumors are incorporated in there. So as a standalone test, it wasn't going to tease those lesions out between those things. So you needed other imaging to help you. But in summary, for the incidental lesion of what we have got so far, is that yes, you can use it altogether. So if you've got a Leydig cell tumor, usually they're not as big as what I'm showing you here. They're usually quite vascular, and that vascularity stays for longer with the contrast-enhanced ultrasound, and is not quite so hard with your elastography. And these are the things you're trying to differentiate in the incidental indeterminate lesion, whether it's a malignant or a non-malignant Leydig cell tumor. The seminomas are more homogeneous. The mixed germ cell tumors are not so homogeneous. The vascularity is not so pronounced as the Leydig cell tumor, and it washes out. It's vascular, and it washes out quickly. And we'll look at the time intensity curves at the moment. And usually it's much harder. That strain ratio is really very hard. So you've got something that with all this combination, you can probably home in on that indeterminate lesion and decide whether or not you want to do it. But you can use your multiparametric imaging in those benign lesions very clearly, because if there is no vascularity and your contrast will tell you there's no vascularity. I haven't got this mouse working. And I'll just play you the video here. I haven't got it. Ah, there you are. Okay, thank you. And you can see how using that contrast, you immediately see which areas of the testes are viable and which have got no flow at all. This is what you call in basketball a slam dunk. There's no doubt that this is black and white, day and night. So it's a very useful tool to tell you that there's no vascularity at all. And you can use it in different areas, segmental infarction, and then you've got an abscess, and you can see the irregularity of that wall quite clearly as well. So you've got a tool that immediately tells you what's going on, and you can pick up the revascularization through an area of segmental infarction and the hyperemia around that area at all. So the confidence in your diagnosis is increasing. Now, what about the differentiation between that Leydig cell tumor incidentally found and the seminoma that's incidentally found? And it's all to do with your time intensity curves. And these are the paper in radiology from Vito's group. And we had previously published a year or two earlier saying that this is what's going to happen with your Leydig cell tumors. So this is an in-house program that we developed looking at the time intensity curve. So if you've got a Leydig cell hyperplasia, it hyper-enhances, and it enhances more than the background testes for a longer period. If you've got a seminoma or a germ cell tumor, it hyper-enhances and then washes out. In fact, it washes out more than the background testes. So you have a test here that should be able to differentiate. So you need to actually do it for about 1.5 minutes, concentrate on that area, and then do offline imaging. Just to touch back on strain and shear wave elastography for the moment, remember I've said that we didn't find such good results, but we add this elastography to our multiparametric imaging because it gives you that little bit more confidence in what you're dealing with. And if you look at these studies at the lower aspect here, when anything new comes out, 2012, everyone jumps on the bandwagon and decides that it's the best thing ever, 100% sensitivity for the visual elastography score. Anybody who reports 100%, you have to be very wary because you can never be 100%. It means you're as good as the gold standard. But if you're better than the gold standard, it counts as negative. So you can't possibly be better than the gold standard. So it doesn't work 100%. PoSA, which used the Philips machine, and I was part of this study, reported sensitivities were much lower. And when we reported ours, we were in keeping with the sensitivity and specificity. So bear in mind, it's not as great as you think it is. So can you now recommend that these patients don't have an orchidectomy? You can do testes sparing surgery on these patients, and this is possible. It's established when you've got bilateral tumors and you've got a contralateral new tumor, solitary testes, optimal management maybe for non-palpable masses. They say 2 centimeters here, but 2 centimeters is like the size of the testes. And you've got things techniques that be able to localize intraoperative and what, just like in the breast as well in theater. So it should be a safe procedure if you're sure of what you're dealing with. So this is a case. We've got a patient who's got a solitary low reflective lesion, which is hypervascular on ultrasound. It's small, it's 4 millimeters across. The strain ratio is not so high. Though the smaller the lesion, the more difficult it is to do. But we've done the curves on this patient, and to us, all intents and purposes, this is a Leydig cell hyperplasia. Put it to the patient. Do they want us to just watch this and see how it goes? Or do you want us to look at this, take it out, and tell you what it is? So they want this out because they're unhappy. So you go to theater, you localize this with a needle. The surgeon dissects down and pulls the tumor out. It's not as easy as you think. You see it very clearly on ultrasound. The surgeon can't find it unless you put the needle into it because everything looks more or less the same at that size, and it's very difficult to find. Most important thing is to put that specimen into a water bath and look at it with your ultrasound to make sure they've taken that tumor out. Then you do a frozen section. And then you can proceed at that time to leaving everything there and come away if it's Leydig cell hyperplasia, or if necessary, proceed to an orchidectomy at that stage because it is a malignancy. So this is how we use our multiparametric ultrasound imaging. But you can just watch these patients. And when would you watch these? Well, you cannot watch them if they are multiple, usually greater than 1 centimeter, mixed cystic or solid, irregular margins, heterogeneous echo texture, hypoechoic, or if there are microliths or macrocalcification. You have to be aware of that. But active surveillance is fine for lesions like this that are found incidentally. And after we usually stay on maybe 6 monthly or 3 monthly initially, 6 monthly and 2 years. And if nothing's happened, that's it. We can finish with it. So yep. In summary, I've shown you that using your multiparametric imaging for an incidentally discovered lesion in the testes, a non-palpable lesion, and this is important, can be managed very differently from the previous management of orchidectomy. And you can either do a testes sparing surgery to get your diagnosis, or you can do active surveillance quite comfortably. And the pivotal issue here is that all of this is done by the imaging person, not the operative person. And you hand this onwards to the operative when you've made as much of a diagnosis as you can. Thank you.